Okay, well, welcome back, everybody. You've had a 15-minute break. I'm very, very pleased to introduce Dr. Jeffrey Kahn, who is the Andreas Drakopoulos, I'm not sure if I pronounced that correctly, Director of the Johns Hopkins Berman Institute of Bioethics and the Levy Professor of Bioethics and Public Policy. His full bio, as with the others, are available to you in your programs. Dr. Kahn is going to talk about ethical issues in vaccination and vaccine mandates. Professor Kahn, the floor is yours. Thank you.
Thank you, and thank you for the introduction and the invitation. Good afternoon to you all. Good morning from where I sit in Baltimore, Maryland, Eastern United States. I am going to speak about ethical issues in vaccination and vaccine mandates. However, to do that, you'll see I'm going to try to frame this for a few minutes in the context of how we think about the ethics of public health from a secular, and by that I mean U.S. Western secular perspective. That's what I was asked to do, and that's actually my expertise, so easy enough for me. I'll be interested to hear your thoughts when we go into the discussion Q&A, and I expect that that will be about 40 or 45 minutes from now in terms of how my presentations fits or does not with your perspective from where you work and live. Okay, so this is a PowerPoint presentation that actually had some animation in it, but the way that WebEx works, it just shows you full slides, so I apologize for that, but pay less attention to the words on the screen than what I'm about to share. I'm setting this up so that you have a sense of where the ethics framing comes from. And so to do that, I want to start with a very brief, and I don't by any means mean this to be a kind of full scope of comparison between clinical medicine and public health, but it's a way I think of starting to set up the difference that then helps frame the way we think about ethics and public health. So in the context of clinical medicine, the focus, at least in bioethics, and again from a Western secular perspective, has been on the so-called patient-provider relationship, the healthcare professional and the patient. That's a one-on-one kind of dyadic relationship in the clinical medicine context versus the health of population, health of community, health of the public from a public health perspective, very different. Second, in the context of clinical medicine, healthcare, the intent of the intervention is to treat and cure illness and disease, of course, versus in the public health context, using largely non-medical, not always in the context of vaccination, of course, is a medical intervention, but means to prevent illness and promote health. So rather than treating and curing, we're talking about preventing and promoting. Third, and this is maybe more important from when we talk about professionalism in the two different contexts, but everybody who goes to medical school learns a very, very similar, if not identical, curriculum. And people who come out of medical school are trained in a way that I think everybody recognizes. Public health is different than that. It's a very diverse collection of disciplinary areas. Some are very overlapping, some are kind of unto themselves. And so there's a kind of collective effort, but people coming from very different perspectives: biostatistics, epidemiology, health policy, international health, reproductive health, and so on. When we start to get into the ethical issues, some of the things that show this distinction that I'm trying to paint are in areas like justice. So in the context of clinical medicine, justice tends to focus on distribution. How do we fairly or equitably or ethically distribute things that are in short supply? This, of course, was important in COVID when we talked about not having enough ICU beds or ventilators or other things that were necessary for treating people with COVID-19. I know this is still an issue around many parts of the world and maybe where you sit. In the context of public health, justice has really focused on a more social justice orientation, things like rights to health or rights to health care, how to address disparities in access and outcomes to health and health care, worrying about individual choice versus the limitations on individual liberty for the good of the public's health. And that's, of course, a very key element for what we're going to talk about for the rest of my presentation. Now, the takeaway here, the conclusion from this slide, is that the different and differing characteristics between these two areas. And as I said, I don't mean this to be a full mapping, but just to give you a sense of what's going to come next, is that the traditional bioethics approaches don't really map well onto issues of public health. And in the US and the Western approach, which has maybe for good or ill become a very dominant way of thinking about bioethics, it has been a very medicine and research on human subjects orientation for very good and understandable historical reasons and institutional reasons, but that has meant that public health has had a kind of difficult and different time trying to take the approaches from bioethics and apply them to public health issues. So this was recognized, not so recently, as early as the late 1980s, and I should just sort of say, as a matter of timing, the discipline, or the field really, because it's not a discipline yet, the field of bioethics in the US really came into being in the late 1970s, so not so long ago, but it has developed quickly, and places like the Berman Institute where I work, and many others around the US and around the world have grown up and do this thing we call bioethics. In the late 1980s, as the last point on this slide makes, a professor who's now at the University of North Carolina named Dan Beecham proposed that there be a recasting of ethics in the context of public health. And it was spurred in a sort of it ended up with Dan Beecham sort of saying, let's think a little differently, but spurred by things that were happening in the US, like the HIV/AIDS epidemic, and realizing that there was a lack of, not a good way into dealing with the issues raised by issues like infectious disease in populations coming from traditional bioethics. And that was, of course, largely driven by a different Beecham, not Dan, but Tom Beecham. Turns out they're not related to each other, same last name, but no relation to each other. And Jim Childress wrote what has become a sort of very famous book, which is now, I think, going into its 9th edition, if I remember correctly. I actually trained at Georgetown, did my PhD with Tom Beecham, so I know him well and this work very well. And the focus on the so-called 4 principles, as are listed here, as the way of trying to identify the ethical issues in a particular biomedical context, and then, of course, what to do about them. These 4 prima facie, as they're known, so they stand on their own principles. They create obligations to behave in particular ways unless they are in conflict with each other or there's some kind of equal or stronger obligation to do something different. Now, I don't mean to dwell on this at all, except to say, of course, this has been the dominant approach, and it just doesn't work terribly well when you're starting to talk about things like ethics in vaccination or ethics in vaccine mandates. It has a little bit of traction, but it doesn't get us all the way to where we need to be. And so, as I said, Dan Beecham proposed a recasting and argued that there should be a rooting, anchoring of public health ethics in access to health care, equity, political philosophy, and democratic theory. So really a kind of different take. And there's an interesting historical discussion to be had about Beecham and Childress and how they got to these 4 principles and why the mid-level principles work in the context in which they were born. But I don't want to do that now. It's a different talk. And so picking up the mantle, so if we go back and say late 1980s, so call it 1988, 89, Dan Beecham was saying we need to think differently. It took a while. Sorry, wrong direction. That Nancy Cass, my colleague here at Johns Hopkins, and in fact a graduate student classmate of mine, wrote a now pretty seminal landmark paper in 2001 that was attempting to stake out the territory around ethics in a public health context. And so what she wrote, and others have followed on, I have done a little bit of writing about this myself, said that there should be values-informed considerations of public health ethics issues, focusing on rights and social justice. And so the way to frame those considerations was to say we, in the context of public health and ethics, should be focusing on improving the public's health and reducing health inequities in whatever way we can, restrained by the three sub-bullets here. We want to do it in a way that has the least infringement or interference with so-called negative rights. That is what we think of as liberty, the rights to be not interfered with. I'll say more about that in a second. Do that in whatever way we can improve the population's health, but with the least interference with individual liberties or their negative rights. And we want to do it in ways that minimize the harms and burdens of a programmatic approach while retaining the effectiveness of that approach. So we want the benefits of programmatic approaches that improve population health, but minimize the harms and burdens that come with that. And there needs to be evidence that the benefits will be realized. So you sort of have to show it will be effective. A more sort of follow-on, so really close behind Professor Cass's work, was a paper that was authored by, again, the same Jim Childress and others. I was in the authorship group of this paper just a year later. So we were working on this paper at the same time as Nancy was working on hers. And luckily we came to somewhat similar conclusions. And we said that there are general moral considerations in public health that need to be attended to. They are the following. We need to produce benefits, they need to prevent harm, we need to maximize utility. So utility in the context of doing the greatest good for the greatest number of people, a population approach. So those are the big ones. Other general moral considerations are the respect for the rights of individuals and justice. Okay, so really following on Nancy's framing very directly. And when decisions about doing things that are in the public's health conflict or can create conflicts among the general moral considerations that we listed and I've listed here, we must have good justification to override them. And those justifications are the following. They have to be all of these things, not just one or some. They have to be effective, they have to be proportional, they have to be necessary, they have to be least infringing, and they have to be publicly justified. Okay, so all of those must be brought to bear as we think about what to do about public health interventions when there are ethical issues raised by doing so. And of course, that's pretty much all of public health raises ethical issues, mostly focusing on restricting individual decision-making or individual choice or individual liberty in the context of doing what's good for the collective. So I've talked fast here so that I leave enough time to talk about the topic that is the title of my presentation today. Last thing I'll say about that before we switch to vaccination is just to put this in a single slide. We want public health interventions or actions to produce benefits and prevent or remove harms with the optimal balance of the benefits over harms. Those benefits and burdens should be fairly distributed. There should be public participation or at least transparency in the discussion and hopefully creation of that action or program. We need to respect individual decision-making, which is, of course, goes back to autonomy in choice and action without necessarily letting people do whatever they want. We need to protect privacy and confidentiality, and we need to build and maintain trust by being transparent and inclusive. Okay, so all of those things need to be taken into account as we think about what to do when there are ethical issues in the context of public health. Okay, so let me frame the ethical issues that arise when we start talking about vaccination. And the red text is what I'm going to spend the rest of my few minutes with you talking about. But it didn't feel right to me as I was preparing these slides to ignore the black text. So let me just say a little bit about that here. So if we're thinking about ethics in the context of COVID-19 vaccines, there really were three phases. The first was the development of the vaccine, which is, of course, unto itself an amazing story of success of the world's scientific community and a lot of resources being focused to bring something from the bench to delivering it to populations in record time, right? So that's a story unto itself. That's the first of those three bullets. The second is that what do we do? How do we manage the prioritization and distribution of the vaccine once it's available? And then the third is what policies do we put in place once there's a sufficient supply. So that was sort of my thinking, and that's why I thought it would be important to include this slide. So let me just say, before we switch to the two bulleted points in red, just a few seconds here about vaccine development, because they raised that whole process raised its own set of ethical issues, and I just want to acknowledge that. So it was sort of in if you were to categorize the issues that were sort of most pertinent for people like us in the bioethics community, it was really an ethics of clinical research question. How do we do early phase clinical research and all of the phases that clinical research demands in an ethically acceptable way during a pandemic, trying to produce a vaccine to be made available, but of course we want to make sure it's safe and that it works, right? Safe and efficacious. And so there was the traditional discussion about how to set up clinical trials, which of course to the gold standard, and to get a sense of whether something's actually working, you have to do placebo-controlled and blinded trials, which means enrolling people into research and making it known to them, and then randomizing them such that some will get the thing you hope will actually prevent infection, and then some will just get placebo, knowing that there's going to be exposure and infection and probably illness. So how do you manage that? So there's a whole set of issues related to appropriate risk-benefit balancing before you can even present the opportunity to participate to individuals. You need to know how many people you need to do these trials in a way that will be sufficiently powered to get information that will allow you to proceed. There needs to be a process of informed consent that allows people to decide, right, for themselves to voluntarily participate in this. Again, all in the context of the raging pandemic and our need to get this through the pipeline as quickly as possible and available to use. And then because of this very particular and somewhat new situation, there was a lot of talk about the ethical acceptability of so-called challenge or intentional infection, human infection trials. So recruiting people into clinical trials with a candidate vaccine, and then rather than waiting for them to be exposed and potentially infected in a community context or a employment or workplace or whatever context, dosing them intentionally, so-called intentional infection or challenge trials, and whether that would be ethically acceptable, knowing that it may in fact speed up the process and make a vaccine available or candidate vaccines available much more quickly, or at least somewhat more quickly, and of course time meant lives. And so how to think through those issues, that was a raging debate here in the US, and I know other places in the world. In the end, it didn't happen, didn't need to happen, partly because the conversation, I think, took a long time, and partly because the sort of more traditional process yielded great results, as we know. Okay, so I'm not going to talk any more about that, even though that's an hour-long ethics discussion, in a slide presentation unto itself. So I want to just bracket that and then focus on the two highlighted or red font points here. So first, talking about prioritization and distribution. So the first issue I want to talk about is what we do once a vaccine became available, and I want to first frame the next part of my presentation. So it's probably obvious to all of you that there's a kind of classic public health ethics issue here in the context of vaccination. So when we talk about ethics in vaccination, whether it's COVID or MMR or DPT, HPV, any of the vaccines, all these different acronyms standing for the various things that they create immunity for, create or lead to a kind of classic tension around the ethics of individual decision-making versus the protection of individuals and the public. And so the classic issue here is how to provide the benefits of what is an available therapeutic that provides immunity in ways that serve the goals of public health, also maximize the benefits to individuals and advance equity, And once these things are widely available, which is, the typical public health ethics issue, how to balance the individual right to choose or parents' rights to choose on behalf of their children, or refuse, with the interest in promoting and protecting the public's health. A very quick side story, which my children will not be angry with me for telling because I've told it numerous other times. I have two sons. My wife and I have two boys who are in now mid and late 20s. And when they were younger, 10, 11, 12, I was very eager to have them vaccinated with HPV vaccine, thinking that it made a lot of sense from a public health perspective, even if at the time that they were of that age, it wasn't widely known that HPV caused male cancers. It has now it's known to play a role in head and neck cancers in men. At the time, it was really only thought to be a high risk factor for cervical cancer in women. And so I said to the pediatrician when I took my kids to see him for one of their checkups, will you start an HPV vaccine series for them? And he said, why would I do that? I said, well, HPV infection is passed by boys to young women, right? So men and women are the way that the virus gets passed. Seems to me if you vaccinate the boys who will become men, that may actually help prevent infection in women. And he said, well, we don't do that. It's not approved for boys. I said, well, okay, I'll pay for it myself. He said, no, it will have no benefit to them. So that was the sort of at the end of the day, the reason he thought it didn't make sense to vaccinate my boys when at that time it wasn't thought to be of benefit to them as individuals. And so that to me was a really interesting issue. I said, I don't agree with you that that's not a good enough reason, that the benefit to the public or to the women that they may have contact with is insufficient to justify whatever risk you think HPV vaccination poses to them. And we got into a very interesting discussion, and that didn't end well for me, at least. And my boys only got vaccinated when they were much later and at their own choosing, because that's when it became available to men. So my point here is to say there's a balancing that gets discussed and struck, and we think not just about the benefit to the group, to the population, but also to the individual when we think about what is the way to think about maximizing benefits and minimizing burdens or harms. So the general approach in answering this question in the context of vaccination is that, again, harking back to the slides I showed earlier, what is the way to most effectively achieve the public health and individual health goals, do them in a way that is proportional in their intervention, right? How much do they infringe on the individual or have some other kind of burden? Are they necessary to achieve the public health goal and do whatever, only what is necessary and most effective and most proportional, and do it in a way that's least infringing on individual rights? So that's a very typical discussion that we have in the context of ethics and public health policy. Okay, so that is a sort of general framing of the issues that now will come up. In the context of that first red highlighted bullet, I want now to talk about the ethical issues in implementing vaccination programs. So that by this I mean when vaccines become or became, we're talking a bit in past tense here, available here in the US, we had a very different conversation than we're having now about mandates. So early on, there wasn't enough vaccine, right? Remember that the first vaccines, Pfizer and then Moderna, were available, but in very short supply, at least short supply compared to the numbers of people who wanted access to it. And so the discussion was, how do we make it available in a way that is most ethically acceptable, practically workable? Unfortunately, in our country, in the US, it became about politics. And so one thing to highlight is that the vaccines, of course, were not approved, but rather made available for use under something that's known as an emergency use authorization. Those should actually be capital EUA, because it's a term, it's a thing that the U.S. Food and Drug Administration, FDA, actually issues, an EUA. And as I'm sure you also know, we're waiting somewhat expectantly for the FDA to grant full statutory approval to one or more of the vaccines, and so moving it from EUA to full approval, which will have some salient effects, I think, on what happens on the mandate side. But all by way of saying, when the vaccines were first allowed to be used on the population under EUA, we all kind of thought that there would be a set of guidance, set of approach, and an approach to doing so that respected some of the kinds of principles that I've already articulated for you. And we didn't know who was going to do that or how, but we hoped that it would be coming from places like our Centers for Disease Control and Prevention, the CDC, or the FDA, or someplace. But of course, to take you all back, I'm sure you don't need me to say this, but this was during the last presidential administration in the US, the Trump administration, and they wanted nothing to do with trying to answer this question. And so US states were left largely on their own to figure this out. And to just remind you, I know you're not in the United States, and so I don't mean to be giving you a civics lesson, but there are 50 states in the US, each of which has its own government, an executive called a governor, and then who's an elected official, and then appointed professionals who run the public health department or the health department, whatever it's called in a particular context. So we have 50 versions of this story, 5-0. It's sort of a crazy thing to say in a very advanced democracy, that you sort of say, we'll just have 50 versions and that's okay, but that's literally what happened. And where I live in the state of Maryland, which has a lot of people who work on public health, pardon me, and medicine and ethics and those things, we were in pretty good shape in helping our state government in trying to answer these questions. But you know that wasn't true 50 times over, and so there was a wide variation in what places did, and so there were tiers created for who would get access first, which were based loosely on those at greatest risk, those most important to keeping society running, which really meant healthcare, frontline, first responder professionals, because if those people got sick and were unable to work, that would be the worst possible thing. And so it was sort of who was at greatest risk and most important, they should go first. Then those at greatest risk of, if they got infected, they might become very sick or die. And then a following of age tiers. So the oldest first, and then where those age categories broke was different in different places. And the timing for how long only first responders were getting vaccine versus who then came next was different in every state. And so, as you might guess, people went to places that they thought would allow them to get access earlier than maybe where they otherwise were. And so in some parts of the United States, that's easier than in others. The part of the United States where I live has relatively small states geographically speaking, and so it would be very easy to go from where I live to five other states within probably an hour's drive. It's not hard at all. Turns out not to have been such a great idea, because our approach was probably as good or better than any of the others around us. But some people got on airplanes, believe it or not, or drove a long way and went from where they lived to Florida, which had the most, the earliest access to people who were not first responders, and did so by people who were over 65 quite early on. And so people who wouldn't be eligible in their home states for a number of weeks or maybe even months went to places like Florida. So anyway, all by way of saying not very well thought out, even though we kind of knew what the right approach should be, right? We want to minimize, right, harm, maximize burden, do so in a way that allows greatest access to those who need it most first. There's not very little discussion at this point about infringement, because we're not infringing on anything. We're rather trying to make things available when there aren't enough, okay? The additional challenges in the entire discussion really focused on a few different things, but there were just these different approaches within different parts of our country. And then it was very unclear from week to week, which was how the supply was distributed, how much each state was going to get, and why. It was just it seemed very random. So we didn't know whether we were going to get 8,000 doses next week or 50,000 doses or 1,000 doses. And literally it was like that week by week. And there was a committee that I was part of that had to decide, what are we going to do this week to allocate doses within the Johns Hopkins University health system allocation. And that was repeated inside our state and then 50 times over across the US. You can see a mess. And it wasn't good as a result. What happened then was that there were incredible challenges for access. So here we get into the ethics, right? So just because we said only the first responders or only those over 80, it's their turn, it didn't mean people, one, paid attention to that, and two, we didn't have a good way to reach those people. And so it meant even if you were eligible in your category, and mostly after the first responders I'm talking about, because healthcare professionals got very good access and it was easy enough to do. But for the age tiers, not every 80-year-old or over 80-year-old has is the same access to the internet, because that's how we got people to register, to transportation to get to a clinic, to even the information knowing it was their turn. And so there was an incredible challenge in making sure that access to this life-saving or life-preserving thing was made available in an equitable way. And by that, I mean a fair way, a way that respects justice as fairness. And so in particular, the equity issues became clearly about the same people who were being hardest hit by COVID-19. So a kind of double equity problem. And for whatever reason, and we still don't really understand, COVID-19 illness disproportionately affects communities of color in the United States. And so and those same communities have less ready access to high quality healthcare, just because of the way our healthcare system, to call it that, is a little bit of a stretch, works or doesn't work. And so the same people who were hardest hit, or the same communities, I should say, that were hardest hit by the illness, also were least able to get early, even appropriate access to vaccination. Add to that some hesitation on the part of those communities to being among the first who would receive something that was new, and in at least one way of thinking about it, untried, a seemingly experimental thing being injected into their body. So we had all sorts of issues related to trust. As I mentioned before, we tried very hard to communicate what was happening and why. Equity, distribution were big problems that I don't think did a terribly good job about managing. It turns out that there were significant legal issues as well. And so just because our country has lots of laws and lots of people like to use the laws in ways that seem to serve their interests, there were lawsuits asserting that there needed to be better ways to make sure people had equitable access. So we ended up doing things like putting vaccination teams together and sending them out in mobile clinics, which of course was complicated, but made more so by the fact that the early vaccines required 2 doses some weeks apart. And so you had to go twice and find the people again to make sure that they got their second doses. And so anyway, lots and lots and lots of logistical challenges, some of which were sort of forced upon those who were delivering care, but always, I think, with the idea that we need to do this in a way that respects the ethical issues that we think are important. When the Johnson & Johnson vaccine, which is the only single-dose vaccine available in the US, but if you live in a place where one of the other single-dose vaccines is available, replace that with what I'm going to say about Johnson & Johnson, because AstraZeneca has some of the same features. Some places decided that it would be efficient. So going back to efficiency, for the intervention, that it would be a good way to get to communities that were having a hard time getting access at all, let alone 2-dose access, to go out and offer them the single dose vaccine, Johnson & Johnson in our case. However, that got portrayed as limiting choice. So individuals said, well, wait, why do the people who can make it to the clinic at Johns Hopkins get to choose Moderna or Pfizer, and we only get access to this J&J, this newer one, this one that no one has gotten yet. So why are you trying out this new thing on us, and why don't we get to choose as well? And so while there was a very good sort of ethics basis for doing the single dose more effective in terms of public health goal approach, it had some significant ethical issues pushing against it, right? It restricted choice in a way that people felt was inequitable. And so that was complicated, unfortunately, by the fact that there were some very rare but notable side effects for the J&J, similarly for the AstraZeneca vaccine, which then made people worry about whether it was the right one for them to get, especially when there was a pause on the use of J&J in our country. And so then people thought, well, why are you giving me this thing that seems to have the side effects when there's this other thing, these other vaccines that don't seem to be having those problems? I want the good one, you're giving me the bad one. And so all sorts of concerns related to equity, which were being driven by a very good and appropriate desire to be efficient, right? So efficiency was the goal, public health outcome was the goal, but that ended up being viewed as a problem of equity and limited trust. All of this was overshadowed in some way by politics, and I guess I've said that, I've nodded to that a little bit in what I've said so far. To the extent there was any process at all, and I put process there in scare quotes because I'm not sure that that's really an apt term for what happened. There was a lot of work done, very scattered. There was not a sort of organized approach in many states, let alone across our country. And so we were, very much influenced in the way this all happened by the politics of the COVID-19 pandemic response, which is, I'm sure I don't need to recount to you, very challenged and challenging still. So there's a couple more slides, and I apologize again for all of the text all at once, but bear with me here. Once there has been enough vaccine supply, and that's of course where we are now, at least in the US. Now, of course, many of you are living in places where you're dealing maybe more with these issues than with these issues, but let me just sort of give you a little bit of a sense of where we are now and hopefully where you will be when there is sufficient supply in countries around the world. And so once there's sufficient supply, there was, of course, then a move to how do we get everybody vaccinated? And I came in at the tail end of the last presentation when there was some talk about herd immunity. How do we get to this elusive thing called herd immunity? And so we had a presidential election, as I'm sure you all know, last November. President Biden made a very clear focus of his campaign and his administration to make our way through the pandemic and he set certain milestones for what that would look like. One of them was by July 4th, which is our Independence Day in the US this last July, there would be 70% vaccination among adults over 21. That would be a way of getting us towards this elusive thing called herd immunity. Did not achieve that. Depending on what statistics you look at, we're very close to that now, so it's not terribly long after, but we're not, we're not quite there, and certainly it's not just people over 21 that matter, of course. The vaccination is now available to be used for down to 12-year-old children, at least one of the vaccines here in the US. And so there's now a bigger population for the herd immunity number to be measured against. All of the discussion about what policy should be in place, about mandates or requirements or incentives or disincentives need to be understood in at least the U.S. context, and I think there are versions of this being repeated all over the world in the context of politics, and I use Trump there very intentionally. It's a double entendre, and I meant it to be. And unfortunately, we are living with the aftermath of 4 years of an attempt to confuse people about the pandemic and what to do about it. And so politics has really, unfortunately, been much more important in how public health policymaking has happened than I would say, ethical issues or even, frankly, public health considerations. Certainly, attention to public health ethics has been quite limited. There was early on talk about what we might be able to do more on a kind of incentive-based approach, and that's what immunity passports, so-called, are meant to indicate, at least on this slide. And you may know that some countries have, with some success, implemented immunity passport processes, which would allow people to do things that they otherwise would not if they don't show that they have been immunized or gotten infected and recovered with a physician's note or noted in their healthcare record that has been the case. And so it isn't that you're restricted if you don't show your immunity passport, but that you're permitted to do things like go to public gatherings, to concerts, I think restaurants. So sort of thinking of it as a way of creating an incentive, a carrot, rather than a stick. Of course, the line is very fine between those two things, because if you say, well, wait a second, I always got to do those things before without having to show any immunity. I got to go to concerts. I got to go to bars and restaurants. Why do I not get to do that now? It feels like a restriction. So it's all in the framing, but at least the way that immunity passports, green passports, vaccination passports were meant to be portrayed, it was really more around incentive and carrot rather than restriction and stick. Still concerns over equity, because it sort of makes sense to say, well, you need to show this if you're going to do these extra things in a context where supply is sufficient. In many parts of the world, that's not true. And therefore, if you're restricting things like international travel to those who can show immunity passports, then there are real concerns over equity, because only those in the richest countries will have access to international travel and border crossing, and those who are yet still waiting for access to vaccine won't be able to do so. So we create an inequity by implementing processes like this. We've had in our in the United States, focusing again here on my own country's context, we've had orders from some states, those that have strong sort of Trump-like Republican governors, that's the chief executive, saying that there will not be immunity passports in my state. They've even gone so far as to say there will be no mask mandates permitted. There's a big fight going on in Florida, which is a big state here in the U.S., where the public schools are opening this week, where the governor of Florida has said he is prohibiting mask mandates from being implemented by school districts. So you can't say to come back to school that the students and the teachers must wear masks. And some of the school districts are saying we're going to do that anyway, take us to court. And so we're having all sorts of crazy discussions about even mask mandates, let alone vaccination. So there'll be no vaccination passports permitted in Texas, in Florida, some of our other sort of more southern states. We'll see what happens. State of New York and the city of New York now, I think, has gone the farthest of any place, locality in the U.S. And I don't know that they've announced how exactly they're going to implement, but there's something called an Empire Pass, which is their state version of an immunity passport, which the city of New York has said that they will use, that will be required for people to go indoors to restaurants, shops, concerts, venues, anything of that ilk. So they're the first to try it. We'll see how it goes. I think more widespread and likely are what will be, rather than public and governmental mandates, there will be employer and institutional mandates for vaccination and mask wearing. Not that we're talking about masking, but since I brought it up, I'll just say it again. That's already happened. Many universities like my own and other institutions have said to come back in the fall, you must be vaccinated, show proof of vaccination, or have a certified exemption to doing so. We're going to be required to wear masks indoors for the foreseeable future. And there's been a guidance from a part of our government saying that private employers are able, under the employment laws, to justify mandates for vaccination. And of course, all this will be much easier to manage in the context of full FDA approval, which I just saw this morning. Some comments from Tony Fauci, of course, well known to you all, that they expect and hope that there will be full FDA approval before the end of the month of August. So we'll see whether that happens. We, of course, still have big challenges around vaccine hesitancy, nicely put, or vaccine refusal, for reasons that may be well-founded or mostly not so well-founded, and other obstacles to getting to herd immunity, as I know you talked about at the end of the last session. So that's, I think, still a bit of a far off and elusive goal, unfortunately. And we, of course, have circulating variants of varying levels of infectiousness and severity. So last thing I'll say, and I'm sure any of you who work in hospital settings can endorse or sort of check this. There's just real distress on the part of the professional staff because they have been working like crazy over the last 18 months, and it's not letting up. The numbers are getting worse here, not better, and I know that's true around the rest of the world as well. All right, I know I'm at the end of my time, so let me just wrap up with this last slide. So just some high-level takeaways, since I got a little bit into the details there. So there's a long history and a kind of clear set of frameworks and approaches for addressing ethical issues in public health, which include the issues raised by vaccine distribution and prioritization, as well as vaccine policies, and including mandates. So we know how to do this. We just, I think, are getting caught up by politics. Whatever those public health ethics considerations are, they've been vastly overshadowed, it's an understatement, by the political calculations and maneuvering that have overtaken the COVID-19 response. And I haven't said anything about this. It could be a topic of another lecture altogether, but the issues around global ethics, global health ethics, have received very little attention here in the US. The announcements that we're sharing a few 100 million doses with the rest of the world sounds good, but depending on what numbers you like, we need something on the order of 10 billion with a B doses of vaccination to get us to anything like herd immunity for the globe. So a couple 100 million is a lot, but it's a tiny fraction of what is necessary. And we're all in this together. We're just not behaving that way. So I will stop with that. I've left us 12 minutes, sorry, and I was aiming for 15 for discussion, Q&A, whatever you like. So thanks.
Thank you very much. That was a terrific coverage. We don't have any questions on the Q&A so far, but if I might take the liberty to ask you if you can elaborate a little bit about you mentioned the states of Florida and Texas and the sort of contrary approach that they're taking. What kind of arguments are they presenting from a policy perspective with regard to what they're doing? Is it is the idea of a freedom of individuals, freedom of choice, or is it more than that?
Yeah, it's not really more than that. I think it's wrapped in we don't know enough yet. It's up to you to decide what's best for yourself and your children, and I'm the one who will protect your right to do so. So it's really a a calculation about what will advance the politics of the individual in that position. It is really not about public health. It has nothing to do with public health. It has to do with, in the case of Florida, Governor Ron DeSantis, who's aiming to probably run for higher office at some point. And so he's trying to be the one that will be the defender of the rights of individuals in this context. And I will say it's unfortunately become a wedge issue, as we call it, a way of driving a difference between groups of people, the voters in the state of Florida in this case, and himself and who he might be running against in the next election, which is of course not how we want to be thinking about public health, but that is what has happened. And so the federal government or the country ceded, and I gave up its leadership very intentionally during the Trump administration and said this is a state level issue. States should decide for themselves. And once that happened, it doesn't really matter that the current presidential, federal administration thinks that we should have a federal wide approach. It's too late for that. And so it's going to be a situation whereby each state goes about this the way that they think is best, and that unfortunately is very much driven by politics rather than public health.
Right. Do you think that the outcome of this will mean more infections and more deaths in those states, and will that then create a rethink?
I think the answer is undoubtedly yes. It has already, right? So the state of Florida has the highest rate of infections and hospitalizations anywhere in the country at the moment. What's interesting is it's interesting that there have now been some very prominent Republicans, and I hate to be focusing so much on the politics of the United States, but there have been some very interesting prominent Republicans coming out in favor of vaccination, saying get vaccinated, because those who are not vaccinated, of course, are at much higher risk of infection and illness. And that's the base of people who vote for the Republicans. So I think they're seeing it now in their political self-interest for people to get vaccinated. It isn't that they object to vaccines or vaccination or public health. It's that they saw it as a political win, a political wedge issue to use. And so now that people are disproportionately getting sick, infected and sick, and potentially dying in a way that affects the base, the political base that they need for their ongoing elections and success, they've changed their tune somewhat. So there's absolutely a public health effect of all of this refusal or policy level hands-off approach. It's really unfortunate.
I have a question from Yasmina. I find this relationship between personal liberties and public health quite difficult. Isn't it unethical from a government point of view to not make the vaccine an obligation? Because you know what the consequences are.
Yes, I understand that. And a lot of the framing of this is very dependent on the cultural and societal context in which we're having the conversation. So the United States has long been and remains a very individual focused country. We think a lot about the role of our government vis-a-vis telling us what we can and cannot do as individuals and the limitations of that. And so the Constitution of the United States, as people I may be familiar with, has something called the Bill of Rights. And those are really all an articulation of individual liberties, and they're liberties that speak to the limits of our government of interfering with our rights to do certain things. So they're not rights to positive things, they're rights to non-interference. So the freedom of speech is one about the government isn't the limits of the government in interfering with individuals speaking out as they see fit. Freedom of religion. The government can't tell us what religion to or not to participate in or believe in. There's a lot of debate, as I'm sure you may know, about the right to bear arms, to own guns, which is about the government's ability or not to interfere with your right to own and keep a gun. But none of those say anything about the government giving you a gun or unfortunately giving us health care. So there's no right to health care in the United States. It's not part of our Bill of Rights, and it's never been articulated as that. And so the context of our conversation is about how much the government can do to infringe on our rights to decide for ourselves. And public health is all about that, as Yasmina's question points out. And so for us, it turns out to be a really hard thing to do, to require people to do something that doesn't allow them to decide for themselves. And even in the context of childhood vaccination, where there's obviously a long history of track record of saving many, many lives, we still have a problem of parents saying, I want to decide for myself whether this thing is good for my child. And in some parts of our country, very high rates of vaccine refusal. And we have outbreaks of things that you would think of shouldn't happen anymore, like measles, like pertussis. We have outbreaks of diseases that should be disappeared from childhood, infection. And so I understand the question, and it's hard for me to articulate it any differently than I have, except to say in liberal democracies where there's so much focus on individual liberty and decision making on behalf of the individual or the individual on behalf of those who are they're responsible for, it's very difficult to mandate anything that's in intervention that interferes in the bodily integrity of an individual.
Thank you very much. The next question is, in what way do you think the manufacturers and government, possibly through public-private partnerships, can improve pandemic policy initiatives to speed up the global vaccine supply chains?
Yeah. Well, it feels like the global vaccine supply chain is as sped up as, we worked really hard on that. And so that's less about, it's less the conversation that we're having than one about how do we make sure that there's sufficient supply in places that weren't the first to invest in, reserving doses or invest in the research and development. And of course, there have been lots of good ideas and actually policies put in place. COVAX, right, the WHO effort to make vaccine doses available across the globe. It just hasn't been enacted. It hasn't been, put into place, or the levers haven't been pulled to make it happen. So I think that there's a more collective way of thinking, at least in our current presidential administration, but we're of course way behind, and there's still a little bit of a America first, even in this current administration, that we need to take care of American lives before the lives of the rest of the world, which is unfortunate. But that's, I think, the reality. I thought, that when the global supply chain showed how fractured and fragile it was in the course of the pandemic, that would be a kind of aha moment, a wake up for the world to say, well, we need to think about this differently. Borders don't matter when it comes to infection and infectious disease. And we need to make sure that the things that we all rely on each other for continue to happen in an easy, friction-free or less friction way that the vaccinations can help. So it's a very cheap investment in something that will, bear lots of not just public health results, but economic results. But the world hasn't yet come to that realization, I'm afraid.
Thank you. In the next comment, in terms of issuing the vaccine passport to those who have been fully vaccinated, don't you think that will create deviant or a wedge amongst many?
It already has in our country. So again, this is a feature of the U.S. health system. I think lives in a very particular place this way, but I'm sure it's repeated other places in some version. We don't have a system, so there's no federal system by which we have our health information stored. So it's very difficult for us to figure out how to do this. And so I would pull that out of my pocket, but it isn't with me at the moment. A card that I got when I got my my Pfizer vaccine doses. And it's literally a piece of paper. I mean, this is 2021, and we have little index cards that have a sticker on them that have the serial number of the vial and somebody's signature on the and the date that I got the vaccination. Now, to the point of the question, that's very easy to counterfeit. And there's already on eBay, those cards are available and ready to be purchased for very little money. So those who want to have the ability to show a passport but don't want to get immunized it'd be very easy for them to do so. What we're being asked to do is take a picture of our cards and upload it somewhere. That's what we're doing at Johns Hopkins where I work. Anybody who got vaccinated at Johns Hopkins, it's in the system, so that's a little bit more reliable. But otherwise, it's very much kind of the honor system. You have to just trust that the person is presenting something that's what it is, rather than some counterfeited version. So it's absolutely a problem. And it's interesting that the global community hasn't really confronted this issue before. Of course, it's a once in 100-year pandemic, but it's not like we've never been immunized and had to show that we've had immunizations. And so you'd think we would have had a ready answer for this. But like so many things in the context of the last 18 months, we were just not well prepared, and we didn't think ahead, and we have to do better next time.
Thank you very much. I think Qatar might be more advanced. I have a official paper stamped, and when I got the vaccines, but I also have digital, two forms of digital official certification of the vaccine. So
it's interesting. Yeah, well, I think many parts of the world are more advanced than we are in this context, but that's because we have such a fragmented healthcare system in the US.
I think you explained that extremely well. Thank you so much. Okay, thank you very, very much. We will now break for another 15-minute break, and then we'll come to the last session at 4 o'clock Doha time in 15 minutes. So please return at that time. Thank you very much, Dr. Khan. Very grateful to your presentation.
Thank you. Enjoy the rest of the day.